Let's take a look at the case of a 52-year-old woman who came to the office having broken off the tooth of her mandibular right second premolar approximately 1 month prior. Now, it wasn't hurting her, and so that's why she didn't come in, and then she started feeling some discomfort, so she called the office and scheduled an appointment. She's basically healthy, although she's on verapamil for some mild hypertension, otherwise has no other issues. She's got no known drug allergies. Discomfort was her only symptom. She had no reports of any swelling or drainage in the area, so that's good. When we do our clinical exam, we can see that the crown of tooth number 29 broke off at least a month ago. There's no tooth structure visible at all supragingivally, and all we can really see is a little bit of a root that is basically covered with some inflamed, angry-looking granulation tissue. At least superficially, there doesn't appear to be any purulence, and it does not look like there is any swelling either on the buccal or the lingual aspect of the alveolus, and extraorally she had no swelling either. Radiographically, no surprises here. We see that tooth number 29 had a root canal treatment sometime in the past. It also had a post and core buildup, and you can see that the post is actually missing. It probably broke out with the crown. And we can see a slightly widened periodontal ligament space on the mesial and a little tiny periapical radiolucency. The patient would like to replace his tooth after extraction with an implant-supported fixed prosthesis, and so we're going to use our atraumatic extraction technique to remove this tooth, hopefully without sectioning it and without removing any of the surrounding alveolar bone. I always like to do an immediate implant at the time of extraction, especially for anterior teeth and premolars, if it's feasible, because that's going to give us our best result as far as maintaining bone level and soft tissue anatomy. But the patient financially couldn't afford to do that at this time, and so we're going to delay the process, but we're going to preserve the ridge using our ridge preservation technique. But I'm going to show you a slightly different technique from the usual in this case that I was able to use because I didn't have to lay any flap to the buccal or lingual in order to get this tooth out, and so we'll call this kind of a minimally invasive ridge preservation technique. In order to remove this tooth as atraumatically as possible, we're going to use one of my favorite instruments, the proximator, which I get from Carl Schumacher Instruments, and what you see there is known as the straight spade proximator. It also comes in some other configurations such as a mesial side spade and a distal side spade that are slightly angled, and it comes in two different sizes. But for the most part, I use that straight spade almost 95% of the time. So the way it's used, and in this case you see the angled straight approximator, is it's advanced down the periodontal ligament space on the mesial, the distal, on the lingual, on the buccal, and as it goes down the PDL space, you're expanding the alveolus as well as severing the periodontal ligament, and as you go around the tooth and get deeper and deeper, it can actually get down near the apex of the tooth and displace the tooth out of the socket. So as you'll see in the video, I really didn't need to reflect much of a flap at all to get this tooth out, and so I'm going to avoid undermining the mucosa, which will allow me to do this minimally invasive ridge preservation technique, which will use the usual freeze-dried bone graft, mineralized corticocancellous, but rather than a cytoplast membrane, we're going to use a collagen plug, and that barrier will be supported by applying a thin layer of cyanoacrylate. This is a very straightforward procedure, and so we're going to do it with local anesthesia. And the technique that I like to use is to infiltrate some 4% articaine on the facial aspect and on the lingual, and that should give us pretty good anesthesia in order to do the procedure. We don't really need to do a block. And of course, if the patient wanted sedation, we would do it, but she was just happy doing this with local and getting it taken care of. If she was coming back on a different day to do this, then I would start her on antibiotics and chlorhexidine rinse 2 days beforehand. But since we're doing it on the day that she presented, I'm going to give her an antibiotic pre-medication of 1 gram of amoxicillin about 30 minutes before we start the procedure, and also have her rinse with some chlorhexidine rinse. I'm doing this because the site appears to be chronically infected, and the fact that we're going to be placing an implant, in this case the implant will be bone and membrane into the site. So a double dose 30 minutes before we start should give her an adequate blood level for the procedure, and then of course she'll follow up with both chlorhexidine rinse and amoxicillin post-op. So we'll use a curved surgical curette to clean off some of the granulation tissue so we can see the root a little bit easier, and then come in with a number 15 scalpel blade to remove that inflamed mucosa and further visualize the root. Then we can come in with our spade proximator, and we're going to, as showed you, advance that down the periodontal ligament space on the mesial, on the distal, on the facial, and on the lingual in order to sever the PDL and expand the alveolus. At the same time, we're going to be working this down apically in an attempt to try to displace the tooth occlusally. So we're going to go from side to side, back and forth, and this takes a few minutes. And each time you notice that as you make a pass and try to wiggle the proximator down the PDL space, that it goes a little bit deeper each time. And now we're going to go on the facial. And as we're working it down, we notice that the tooth is starting to move. And before we can stop it, the tooth basically just flew out of the socket. So we were able to displace it inferiorly from the facial going down the PDL space. And of course, two things can't occupy the same place at the same time. And the root came out. So then we thoroughly debride out the socket, use the curved molt surgical curette. We're doing this under lights and loops, so we're seeing exactly what we're doing. And then we're going to cut our collagen plug, and I cut it kind of like a French bread, a little bit oblique. And this is going to make it so that rather than being totally round, it's going to be a little bit more ovoid. Then we're going to take that collagen plug and kind of squeeze it together. And that's going to increase the density. So next we'll prepare our freeze-dried bone graft, which is going to be particulate corticocancellous calcified bone. I like to use Mineros from BioHorizons. And we're going to mix it with an equal amount of either saline or blood. So if the patient's having sedation, we'll draw off some blood. Otherwise, we'll use saline. So it's about 1 cc of saline or blood for 1 cc of bone, and we're going to remove the excess saline with a 2x2 gauze, and then we're going to pack the extraction site. Now this is a premolar, a single rooted tooth, so we're going to use a half cc of bone altogether, and we're going to fill the site incrementally, just packing it down, starting at the bottom and filling up. We're going to use our small bone packer, the small side first, and we're going to pack the bone densely enough that the particles aren't going to float away and that they're closely together, but not so tightly packed that we're not going to get vascular ingrowth. And so as we build up towards the top, we can switch to the wider side of the packer. And when we get to the very top, we can, once we've got the socket filled, we're going to take away the excess, tap it down a little bit with our digital packer, and then we can get the collagen plug, and we're going to bring it to the site which we've cleaned off, and essentially then pack it into the top of the socket. So we're going to completely cover the graft, and we're going to kind of shape it to fill in the defect and to cover the bone completely, and tuck it a little bit underneath the tissue. But to hold it in place, we're going to use a suture using 4-0 chromic gut that I'm going to suture in a figure 8 fashion, starting on the inside and then going towards the outside on the lingual and then on the facial, and then completing the figure of 8, do the same thing again on the lingual, and then back again on the facial. And again, the reason we do it from inside to out rather than outside to in is so that that collagen plug is pulled down towards the graft rather than lifted up when we pass the needle. So final pass is going to be on the facial, and then we can go ahead and tie this off. We're going to do a surgeon's knot with 3 throws, and go ahead and snip the suture so we leave about 2 millimeters of length, blot it off so it's nice and dry, and then we're going to use our periacryl. Periacryl is basically sterile cyanoacrylate oral adhesive. It's basically sterile crazy glue, and you can see little pipettes there. Those are used to draw up the liquid out of that little container to the right that's standing up next to the bottle. And we only need a couple drops for it, a very thin layer. So we're just going to put a couple drops and let it spread a little bit right on top of that collagen plug. We've got our sutures already in place, and then we can use an air water syringe to gently air dry this. Now you don't want to have your syringe blasting because that increases the risk of creating a subcutaneous air emphysema, but a little bit of light air to just sort of accelerate the evaporation process. As this dries, the collagen sponge will get a little bit stiffer, and then you can go ahead and put a moistened gauze on top and have the patient bite down firmly. Post-operatively, we're going to keep the patient on the amoxicillin, 875 milligrams twice a day for 5 days, and then chlorhexidine rinse, a 16-ounce bottle, and we'll have them rinse twice a day for the next 2 weeks, and then see them for follow-up.